Welcome, Dr. McAvey. I'm so excited to have you here with me today.
Thank you so much for having me. This is really exciting, and I'm happy to be here with you today.
So before I get into the great education that you're going to share with us and everything else we're going to talk about, let's start with who's behind the white lab coat. I always love to hear how people came into their profession and any other background you want to share with our audience about who you are and why you picked fertility medicine.
So I feel my pathway was probably not so straightforward. You know, I'm a kid of the 80s. I went to college in the 90s. I actually went to college as a writing major, as a journalism major. But my favorite subject really was science. And so I switched my major in college from journalism to science, and I figured I would find my way from there. So when I graduated undergrad, I ended up at Johns Hopkins University, sort of by luck, ended up in a IVF lab. So this, again, was sort of the early 2000s. IVF was up and coming in terms of field of medicine, and I ended up in a mouse IVF research laboratory. So I was there for 2 years, and from that juncture decided I would go on to medical school. And in between graduating from Hopkins and matriculating into medical school, I ended up working actually in an IVF center in Brooklyn. So I was an andrologist, which is a lab technician that processed sperm. And from there, I went on to medical school. And then from medical school, I ended up at Cornell, in an OBGYN residency, and sort of naturally ended up in, doing furthering my training in reproductive endocrinology and infertility. So I never thought I'd end up here, but when you look back, it kind of makes sense. All the pieces sort of, maybe by luck, a little bit of luck, but maybe it was the fate. And, so here I am 25 years later, more than that, actually, 27 years later. So the time goes fast, but so that's how it happened. But, I came from no medicine in my family.
Wow.
And, first person in my family to graduate from college. So, It just all sort of fell into place, and here I am.
Amazing. It's so interesting to hear what led you to the career you have today. And so let's start with, for those who aren't quite patients yet, maybe they're kind of like poking around, they're not quite yet ready to jump into the protocols, or maybe they're ready to see if they need an evaluation. I'd love to hear your opinion based on the work you do every day in the clinic. What are some of the most common misconceptions people have about their fertility?
I think that the biggest misconception is really just the fundamental understanding of how female biology differs so much from male biology. And I do feel that our societal norms of, when we or, patients feel ready to try to conceive or start a family, I feel like the societal norms, like it doesn't line up with the biological norm. Right. So meaning by the time we've sort of lived through our 20s, or maybe found a partner, or feel satisfied in our career, or feel like we have enough money. And again, I don't know if any of that ever happens, but by the time that happens, maybe the biology, the biological norm has sort of passed, right? So I think that's the biggest misconception, is you can live a very fit life and be somebody that's into exercise and, never have a drink in your life and never smoke a cigarette and be within normal weight. And no matter what, even when you're in your 40s, it likely is going to be difficult to try to get pregnant. And that's because the female ages very differently than males, right? Females do not regenerate eggs. We're born with a finite number of eggs. We start with a lot, we end with a little. There's no female in their 40s that by default has, quote, good eggs or good quality eggs. And so I think that is the biggest misconception. So for patients in their late 20s, in their 30s, if they're not trying to conceive anytime soon, which is okay, maybe they should have an evaluation, see where they stand, consider something like a fertility preservation, so that they can, enjoy the time that they want and deal with it sort of later on. So I think that's the biggest misconception, is time. Time is never on our side for female aging in terms of reproduction.
Great, and well said. I mean, time is definitely not on our side, and it can't hurt to just, get an evaluation.
Right, be seen and see where one stands.
Let's talk about AMH. For those who don't know, what is it?
So AMH is anti-Müllerian hormone. It's a glycoprotein that is secreted by the supporting cells of eggs. It really is just a quantity indicator of the remaining egg pool. So in simple terms, menopausal, meaning no eggs remaining, AMH is 0. That's what it is. There are no eggs remaining. There's nothing else to ovulate. People don't ovulate. They don't get periods. It's called menopause. Younger females typically have higher AMH levels. And then there's, a threshold. We sort of, as we progress through life, the AMH, it's plateaued. And then as you get to the later 30s, early 40s, it goes down. So it's a blood draw. It's a blood draw to see where you are in relation to other people one's age. There are age-specific averages, so mean and median for AMH that exists for all, for ages 24, up until 46. There was a landmark paper published many years ago that really looked at patients just presenting to U.S. Fertility Center, I think almost 20,000 females, and what was their AMH just based on age. So there are charts that exist. And so you can have an AMH drawn just to see where you are for your age. But keep in mind, AMH does not predict the ability to conceive. So this is, should be clarified. We see patients all of the time. They'll go to the OBGYN. They will say, can I have my AMH drawn? The AMH comes back as low. Doesn't mean they're infertile. They can have intercourse that month and get pregnant. It just means that they might have a low egg count. And so will that be important? It could be if one were to be infertile. If they are not able to get pregnant, AMH does have an impact. Because now when you're trying to do a fertility treatment, if we don't have a lot of eggs to work with, the success rates of the treatment often can be lower. So, it doesn't predict the ability to conceive, but we can predict the response and the success at time of a fertility treatment if one were to go forward.
Do you recommend getting your AMH tested regularly? Is that something to consider?
I don't draw it regularly, but I think if one were to be, let's say, in their early 30s, and they're not wanting or trying to conceive anytime soon, but they know they want to have a family at some point, they should check their AMH and they should consider egg freezing. That's the difference now versus, 20 years ago. We didn't do it. We did egg freezing more for cancer patients. Prior to, undergoing a treatment that would render them infertile, we did egg freezing. But now most egg freezing is for, I don't want to say non-medical reasons, because I do think it ends up becoming a medical reason if we don't have eggs to work with. But, so I don't think it's elective. People would used to call it elective egg freezing. I don't think it's elective. I think it's actually medically indicated. It's just not for the reasons that it was in the past.
So let's talk about miscarriage. What are the signs of miscarriage? And not all bleeding is a sign of miscarriage.
Well, actually, most bleeding doesn't lead to miscarriage, right? So we get patients, obviously, who are pregnant and who bleed often, especially in the early portion of the pregnancy, and the vast majority of the time it actually doesn't lead to miscarriage. So, signs of miscarriage really is non-progression on ultrasound. Patients know when they got pregnant, either from natural conception, or we know when they got pregnant because we put an embryo in their uterus at a certain time. Because you know that date of conception, you know where the pregnancy should be. So pregnancies develop in a very certain fashion. There's a gestational sac, so that is the implantation sac that's seen on ultrasound. And about a week after that, you should see something develop inside. A yolk sac is the second stage of development, and then we have a fetal pole, which is the start of the fetus. And really by 6.5 weeks of gestational age, which is about 2 to 2.5 weeks after a missed period, one should actually have a heartbeat. So what it should look like on ultrasound in terms of pregnancy progression. So signs of miscarriage would be abnormal progression on ultrasound. Of course, whenever we have somebody with bleeding, it is a threatened miscarriage. And those patients come in and they'll have blood drawn and have ultrasound performed to confirm that things are okay or not okay.
So what is the most common week to miscarry?
Trimester, for sure. So the beginning portion of the pregnancy. I think there's a really high percentage of what's called biochemical pregnancy, where, patients may not even realize they're pregnant, their period's late for 2, 3, 4, 5 days, and then they do a pregnancy test and it's positive, and then all of a sudden they get a period. And they're like, but I just had a positive pregnancy test. It's a chemical pregnancy, so it never manifested to a clinical pregnancy or a gestational sac or fetus, but there was some pregnancy that was established early. I do think biochemical pregnancy rates likely are very common, for patients, and they don't even realize that they're pregnant. But, certainly the most common is early pregnancy. First trimester is the most common, 95% of losses, I would think.
What does recurrent pregnancy loss mean?
So it depends on the governing body of which society you're looking at. From our, which is from our society, which is the American Society of Reproductive Medicine, for us it's 2 or more consecutive miscarriages without an intervening normal pregnancy. More than one, so 2 or more without an intervening pregnancy. So sometimes you'll have a patient who comes in, they have a miscarriage once, and then they get pregnant and have a baby. Then they come in, they have another miscarriage. Okay, it's really not recurrent because you had a baby in between. So consecutive losses. Recurrent pregnancy loss, the evaluation is mostly on the female, but involves the sperm source or male partner or, to make sure that the genetics are okay on the sperm source. But we look at things like uterine structure, making sure there's not a uterine anomaly, so like a uterine septum that can lead to miscarriage, or uterine fibroids, or uterine polyps, things that can get in the way of a pregnancy from, progressing normally. But genetics are probably the cause of 90+% of miscarriage. So a bad egg or a bad sperm made an unhealthy, unbalanced embryo that led to loss. So whenever we see a patient or a couple that has had recurrent pregnancy loss, we always recommend genetic screening, expanded carrier screening, to make sure that the egg and the sperm source don't carry the same genetic mutation. And then furthermore, we typically send them for something called a karyotype to make sure that either the egg or the sperm source doesn't have a translocation. Translocations can lead to a high percentage of unbalanced embryos, which then lead to miscarriage. But other things we think about holistically, sugar levels, thyroid screening. There are some obscure, either inherited or acquired thrombophilia disorders that can lead one to have miscarriages. So that's the whole world of, I had a miscarriage, then I was told to take a baby aspirin, or I was told to take a blood thinner. That's where that comes from. But you do want to do the proper workup for that prior to telling a patient, to take a blood thinner.
Is it better to miscarry naturally, or do you recommend a D&C?
Early pregnancy. So the options are you wait it out and do nothing. So naturally, wait for the pregnancy to expel. And then there's medicated induction, of the miscarriage, or there's surgical, which is a D&C, a dilation and curettage. There are advantages to all three, and there's disadvantages to all three. The medicine, which would induce a period and induce the pregnancy to sort of expel, is natural, it's hands-off, doesn't require procedure. And some patients really want that, and that's okay. I think the downside of that is it can prolong things. It can take a while for it to happen and be done. Sometimes the medicine doesn't work, and now you're having a second round, and next thing you know, you need a D&C anyway, and you're like, I should have just done it from the beginning. And then I would say the big disadvantage is that you can't genetically test the pregnancy tissue to confirm was it normal or not normal, was it genetically abnormal, or whereas a D&C, the downside is it's a procedure. Sometimes you have to go to the hospital or surgery center. Sometimes you need an IV, you need a day off of work. You're instrumenting a uterus, which could lead to scarring. Generally not so much anymore. Most people are very cognizant of that and aware. The upside is that it resolves it very quickly. And then probably the biggest advantage is that you can send genetic testing on the tissue. So it was abnormal.
Yes.
Although it's hurtful and it was hurtful for me to have this loss.
Yes.
I'm glad I know the information that it was not healthy and I can move on.
Exactly.
So I would say most patients do active management with either medicine or D&C. Most don't just wait for it to happen on their own. At least my patient group.
Good to know. So I like to ask all my guests some rapid fire fertility questions. Rate these fertility topics from 1 to 10. Inositol for fertility.
I would say 4.
NAD.
It's in that same range, 4. To be determined.
Cycle tracking apps for just your period.
Helpful, 6.
Ovulation or cycle tracking apps for fertility.
6.
Low carb diet.
For fertility, I think a 5. I think general awareness of what you're putting in, right? Low carb, eating green, being healthy. Yes, I think it's probably higher than 5, to be honest. I think I'm going to say 6. I'll revamp. 6 to 7.
Okay, that sounds good to me. Now, my last one is, nowadays there's these fertility companies and they're marketing, do it at home, your own fertility. Have you heard about that?
I have.
What do you think about that?
I think there actually might be a home AMH, I think. And I know there's homes, I would say I see a lot of couples come in with home sperm analysis. So
is that safe? I mean,
I actually think it's fine to do.
Even washing it in their home and things like that?
So the sperm analysis is they're using their phone, they produce a sample, they put it in some slide,
right,
and then they literally use their cell phone on an app. I honestly have seen that. It's pretty
and
good.
What are your thoughts?
It gives
really?
a pretty good count. I would say it looks at count and motility. It won't look at something called morphology, which is how it looks under. So you can't do a morphological assessment. But for a simple question of, do I have sperm? Yeah, I think it's pretty good. We always end up repeating it formally. But I actually am in favor, especially patients that don't have access to, they're not in New York City, they're not in Los Angeles. Maybe they're in some remote areas and they don't have access to fertility doctors in the way that we are here in New York. Yeah. I would think do a home sperm analysis as an initial. Why not?
Exactly. And it's more cost effective, right?
Much more.
Yeah.
I think so. Yeah, I'm in favor of it. But these are newer. But the technology is always, advancing.
Exactly. So switching gears, I like to ask all my guests, what is your definition of self-care? And what are you doing nowadays to de-stress and get grounded?
If there's ever de-stress. I think, for myself personally, making time with the family, friends on the weekends. I like to travel if I can. It's hard though with the patients, you don't. So the days of, really checking out and leaving the patients for others to manage, it's kind of doesn't exist, to be honest. So, I try to, you try to travel, maybe not check cell phones after, 8:00 at night is probably a good rule. Try to sleep 6 hours a night. Do something in terms of a physical activity that you enjoy. I like to play tennis once a week. That's pretty much it. I would like to go back to the days of reading. I used to read a lot. I think a lot of people don't read anymore, myself included. Yeah. But I would like to read.
Any particular genre?
More just like I don't say love stories, but, relationship, type books.
Nice. Yeah. Words of wisdom. Can you share with the audience or patients who are seeking their doctor but not have found the right one yet?
I mean, I think it's the day, in today's day, I don't want to call it, doctor shop, because sometimes that's not very effective. It's not efficient. You lose time. But I do think patients have much more say in who they select to see. Some patients want a lot of hand-holding. Some patients don't. Right. Some patients really like it to be cut and dry, professional relationship, call it a day. And some people want really the opposite. So I do think the patient has the right and the choice to find who they want to see. There's so much out there now. There are resources using OBGYNs to refer. So if you love your OB, ask your OB. Right. If you love your primary care, ask your primary care, who should I go see? Friends, family members are very good referral sources. So I would say most of my practice comes from prior patients or friends of friends or, teachers or, it's mostly word of mouth.
Absolutely.
Most of the practice, at least here on Long Island, that is the case. I think New York City is a bit different, but out here in the suburbs, it's really, to me, it's mostly prior success or patients, family members, who say.
Exactly.
But referring OBs are great. Go to them and ask.
Perfect. And I'll leave it at that. Yeah. So where can listeners get in touch with you, perhaps set up a consultation?
Yeah, so I am, I see patients in Garden City, which is down the road from where we are now. It's RMA of Long Island. Garden City is my office, but we have offices in Lake Success, Melville, Stony Brook, Patchogue, and West Islip. So that really covers from Queens kind of all the way to Suffolk County. So it's, RMA of New York at Long Island, and the website is RMA. I don't know. What is our website?
Don't worry, I'll add it all in the show notes. Yes.
I don't know.
And they'll be able to get in touch with you.
Google and find. Or Instagram, you can always message me,
yes.
But probably easiest to just Google and find cell phone, find office number and call.
I'll be sure to include all of this in the show notes.
Great.
This was so nice to have you in person. Thank you, Dr. McAvey.
Thanks.
You're welcome.